Okay, perfect. Thank you, Zoom, for letting us know. I will go ahead and get started. I have the top of the hour here. So again, thank you everybody for joining us today on the third installment in the RCM PPM series. Today's topic is FQHC and RHC coding, documentation, and billing guidance. This event today is being recorded, as well as qualifying for ACHE credit. The credit survey and the link to where the recording will be posted will be sent in an email following the completion of the entire webinar series, so after next week's webinar. My name is Caleb Wozinski, a program coordinator with the National Rural Health Resource Center, which is providing this webinar today. If you would like, you can connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. Thank you to everyone who's done this already. And if you haven't, please take a moment to type your name, title, and organization into the chat box so we know who's joining us today. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is a TA provider for the Delta Region Community Health Systems Development Program. The DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about this commitment on our website. Now, before I introduce our wonderful speaker, Caroline, today, I'm going to go ahead and pull up the pre-polling questions. If you could fill those out at your leisure, that would be wonderful. We'll do some post-polling at the end of the session today, and it helps us measure knowledge gain. All right. So we have our wonderful speaker, Caroline Goldman Hernandez today, and she is a senior consultant with Forvis Healthcare Performance Improvement. She has 5 years of experience in coding compliance, denials, and revenue cycle. Caroline began her career with a large clinical staffing and revenue cycle management company, where she obtained experience in claims processing, process improvement, data analysis, ICD-10 CM coding, AMA, CPT coding, insurance provider rules and regulations, and revenue cycle procedures. Caroline, thank you so much for being here today, and I'm looking forward to a wonderful session.
Yeah. Thanks, Caleb. I appreciate it. Okay, let's see. Let's go ahead and get started. So, everyone, like Caleb said, my name is Caroline Goldman Hernandez. Today, we are going to be talking about FQHC and RHC coding, documentation, and billing guidance. So obviously, there's a lot of information here today. This is just our agenda. I'll do just a quick intro, learning objectives, and then we'll go into like an overview of FQHCs and RHCs, and then some coding and documentation best practices. So our learning objectives for today are listed here. We really just want to identify and get a better understanding of key billing, coding, and documentation requirements for FQHCs and RHCs, while keeping in mind those overall best practices for coding and documentation. So please feel free to unmute, put in the chat if you have any questions. If I can't answer it, I'm sure there's someone at Forvis who can. So I'm happy to take any questions throughout. Just feel free to come off mute and ask. So just diving right in, what is the difference between an FQHC and an RHC? An FQHC is a federally qualified health center, sometimes known as a community health center, that serves as a community-based primary care center. FQHCs provide those preventative services to vulnerable populations that wouldn't otherwise have access regardless of their ability to pay. FQHCs do offer those sliding fee discount scales to eligible patients. FQHCs do require some certification, or they have some certification requirements to be eligible for an FQHC. The center must provide comprehensive services and have an ongoing quality assurance program, including an annual review, meet all health and safety requirements, and are not concurrently approved as a rural health center and must meet all the requirements under the Section 330 of the Public Health Services Act. On the flip side of it, an RHC is a rural health center that is certified to receive special reimbursement for Medicare and Medicaid patients. The purpose of an RHC is to improve patient access to primary care in underserved rural areas. Per certification guidelines, 51% of those clinic services must be primary care. So your family medicine, your pediatrics, your obstetrics, things of that nature. The clinic must be staffed at least 50% of the time with a mid-level practitioner, so your NPs or your PAs. And then there are some specific location and condition requirements set forth to qualify as an RHC. Again, those will fall under the PHA. So what kind of providers can perform these services within an FQHC and an RHC setting? This is probably one of the biggest similarities that an FQHC and an RHC have. Otherwise, they're fairly different. Same providers are eligible in both an FQHC and an RHC. You have your physician levels, so your MDs, your DOs, your mid-levels, nurse practitioners, PAs, a clinical psychologist, your certified nurse midwives, and your LCSWs. So that's pretty consistent across the board for FQHCs and RHCs. So as we talk about the providers that are able to perform those services in an FQHC and RHC, another similarity across these two centers is Incident to services. Incident to kind of seems to be a hot topic right now, so I did just want to touch on it really quickly. Incident to services are considered services and supplies furnished incident to physician services, which are limited to situations in which there is direct physician supervision. So direct supervision, that is anything classified as not necessarily the physician having to be present in the same room as those services being rendered, but it does mean that that physician must be immediately readily available within that RHC or FQHC. Examples of incident to would be assistance by auxiliary personnel, so your nursing staff or your medical assistant, or just anyone acting under the supervision of the physician. Incident to services are considered covered and paid under the FQHC and RHC if they meet the below criteria. And I do have that detailed out for you. So they must be bundled with the FQHC or RHC encounter. So they're not going to be separately billable or payable. So you can't just create it out. It'll all be bundled together. The services that do not occur on the same date as the encounter can be bundled if they occur 30 days before or after. So if they come in, if the patient comes into the FQHC, they do some lab work that day, they have their medical visit, and maybe they come back 2 days later for an allergy injection, and the nurse will render that injection. That would be considered incident to. So just a quick example there. In terms of payment, the effect on payment is an increase in the charge and therefore in the co-insurance. And the costs for these services are included in the cost report, but not necessarily, but not separately payable on claims. So again, just some types of incident to services would be those that are furnished under the physician's direct supervision by a member of the FQHC or RHC staff. It can't be someone outside the organization. It has to be someone employed by the FQHC or RHC staff. Drugs and biologicals that are not usually self-administered would be considered incident to services. So like a patient coming in for an allergy injection, things of that nature. So FQHC and RHC qualifying visits. They're reported a little bit differently across the two services. So FQHCs must include an FQHC payment code on their claim. FQHCs will report one service line per encounter or visit, whichever with the revenue code 052 and a qualifying medical visit from the FQHC qualifying visit list. And I do have some examples of that and some resources at the end of what that qualifying visit list looks like. Payments and applicable co-insurance and deductible shall be based upon the qualifying medical visit line. So depending on what that patient is there for is going to drive what that payment looks like. So An example of what those FQHC payment G codes are, just a few snips here. So the G0466 would be that new patient medical visit. The G0467 is an established patient. You do have a specific FQHC G code for your IPPEs and AWVs, G0468, and then they do offer G codes mental health visits. So again, delineated out between new patient and established patient between the G0469 and the G0470. On the flip side of it, RHCs report one service line per encounter with the revenue code 052 and a qualifying medical visit. So very similar to FQHCs. If it is a behavioral health visit, that revenue code will be the 090 rep codes and a qualifying behavioral health visit from those RHC qualifying visit lists. And let's take a look at what that visit list looks like. So from the FQHC's perspective, this is just a really, it's not all inclusive, but when you're looking at those CBT codes for your medical visits, just making sure that they can, or that they map back to a G code and that you're putting that correct G code on your claim. So if a patient comes in, they're new into the office, and you do, a lot of high medical decision making, you have a good workup on them, you would bill that 99205 under the G0466. So again, this is just a small snippet of what that would look like from the FQHC qualifying visit list perspective. And the same with RHC. So it does look a little bit different from an RHC qualifying visit list. If there are any screenings or counselings performed, you would need to report those using the appropriate qualifying G code. So if they come in for their annual wellness visit and they do an annual alcohol screen, you would put that G0442. So what type of services are performed in an FQHC and RHC? Typically, FQHCs and RHCs will both provide those initial preventative physical exams, so IPPEs, I know I mentioned that earlier, and AWVs, your annual wellness visit. They'll both, so they both have those preventative medicine type of services offered, and then physician services, so mental, medical health, and again, can be rendered by physician, mid-levels, certified midwives, clinical psychologists, and an LCSW. RHCs do have a little bit of flexibility in providing telehealth mental health visits. We all know COVID kind of changed some regulations on us and broadened our perspective in terms of telehealth. So RHCs do have that ability to provide mental health visits via telehealth, but there are obviously some restrictions involved. It is important to note here that when you are billing for telehealth and you're trying to, beef up your documentation to support that telehealth visit, you want to make sure that you're documenting the provider location, the patient location, the fact that patient consent was obtained, and then the modality of the visit. So was it audio only? Was it audio visual? Really want to make sure that those 4 components are documented when you're trying to report telehealth. Some other examples of things that are included in an FQHC and RHC, homebound visiting nurse services. If the nurses need to go to a patient that's confined at home, those would definitely qualify. Some care management services. So new in 2022 for RHCs, the transitional care management is offered. For RHCs, they have CCM, so the chronic care management services, and any services and supplies. That would be furnished incident 2. So again, fairly similar, but they each have their own differences. There are some examples of services that are not covered under an RHC. So that those would be those laboratory services, any DME, and any ambulance services. Just a couple of examples. Those are some instances where they would not be considered services provided within the RHC. So having said all that, these are the locations that those services can actually take place. Essentially, FQHCs and RHCs, they have the same acceptable locations. So again, another small similarity that's between these two. Obviously, an FQHC can take place within the FQHC. Can take place at a patient's home, including an assisted living facility, in a Medicare Part A skilled nursing facility, or at the scene of an accident. Transversely, RHC operates the same way. It must take place within the RHC. Some unacceptable FQHC locations: any inpatient or outpatient hospital department, including a critical access hospital, and then a facility with specific requirements that exclude FQHC visits. So you'll never have an FQHC visit take place in an RHC, for instance. The same for RHCs, won't take place in an inpatient or outpatient hospital department, including a critical access, and then a facility that has specific requirements that preclude RHC. So a hospice facility or any type of comprehensive outpatient rehab facilities, those would not qualify. So now that we know the basics of the FQHCs and RHCs, biggest issue here is, how are they reimbursed? How are these FQHCs and RHCs going to get paid? And this is where a majority of the differences are. So an FQHC is reimbursed based on the Medicaid PPS rate. For those Medicare visits, FQHCs are reimbursed using the GAF, so the Geographic Adjustment Factor. It is based on locality, and it is used against the base rate. So the national base rate is 180. 180. Those IPPs and IPPEs and AWBs, Medicare will pay the FQHC PPSG code at an FQHC's billed charge, or the annual PPS rate maximum, whichever is less. So important to note there, they pay whichever is less, not whichever is more. In those instances of IPPEs and AWBs, the coinsurance is not applicable. From an RHC's perspective, RHCs are reimbursed on an AIR, so the Medicare all-inclusive rate for those Medicare visits, and a PPS for Medicaid visits. IPPEs and AWBs receive full AIR, and the patient will pay nothing. For other services rendered in an RHC, the Medicare pays 80% of the AIR, so that, again, that all-inclusive rate, and the patient pays the remaining 20%. So RHCs differ a little bit from FQHCs. Those RHCs must report modifier CG on one revenue code, so either the 052 or the 090 service line per day for the bundled service. So that CG modifier is really just indicating that the service line is subject to coinsurance and deductibles. So this table just details out where those RHC Medicare claims actually go. We do have it broken out in terms of type of RHC, so that it is independent or provider-based. And then across the top, just the type of visit. So those encounter visits for provider-based, those would go to Part A on a UB04, and it would have the RHC's NPI. If there are any labs, that would go to the parent hospital on a UB04. If there are any hospital or professional services rendered, that will go to Part B on a 1500. And then if you wanted to break it down by payer, which is typically what I think most of us like to see, because that's what's going to drive majority of the decision making when it comes to sending out those claims. We're looking at it by payer type. RHC claims for provider-based Medicare will go to Part A on a UB04, again with the RHC's NPI. For Medicare or Medicaid, for Medicaid and Medicaid MCOs, those will go to place of service 72 with the RHC's NPI. If they are Medicare Advantage, some will pay on an AIR, and again, that will go on a UB04. Others will go on a 1500. So really want to make sure that you're looking at those payer guidelines and just understanding how they want that claim to come through. Commercial, every commercial payer does it a little bit differently. Most do not recognize the RHC status, so those will need to go on a 1500, place of service 11 with the non-RHC NPI. So Typically it's the provider's NPI, but that is what that would look like in terms of payers. So pretty similar between independent and provider-based, but again, just a couple of delineations there. The RHC Medicare payment limit per visit, always like to put this in there. Sitting at 2024, we are at $139. As you can see, there is kind of a steady increase in the coming years. And we've obviously come a long way since 2021. So just wanted to throw that out there for your reference as well. So why does coding matter? What is the importance behind coding? So it really is truly important to make sure your coding is correct. The coding is reflective of the true health of the patient. Your claim is essentially telling the story of the patient. So the CPT or the HCPCS code is telling what happened, and those diagnosis codes are telling why it happened. So you really want to make sure that coding is able to apply those correctly. On the flip side, they can't do that without the documentation. So super important. Aside from the integrity of the coding, payers reimburse differently. So it's really important to accurately report those services to the most accurate and specific levels, so you are reimbursed properly for the services rendered. A lot of the diagnosis codes will always have an option to be unspecified. So anything that ends typically in a 0.9, ideally, sometimes we don't have an option. We have to use those codes, but really want to make sure we are coding to the highest level of specificity, because it truly is telling why that patient was there, and you want it to reflect the complexity and the reason why that patient needed to be inpatient or whatever the case may be. So super important to get that coding correct. Biggest issue we typically see in terms of confusing coding and documentation guidelines, I'm going to say, is the difference between new versus established patient. We get this question a lot. A new patient is defined as not having received any professional, medical, or mental health services from any sites within the FQHC organization within the past 3 years. So if the last time I saw you was in 2015 and you're coming back February 22nd of 2024, you would be considered a new patient. And it gets a little tricky when there are multiple services happening, and that's typically where we see majority of our questions. So if a new patient is receiving mental health services and medical services on the same day, technically you would think that they would be considered new for the two different departments, but that is actually incorrect. The patient is considered new for only one of those visits. So sometimes definitely, and especially in an FQHC or an RHC, we will see a patient come in and they'll have their medical visit at 11 a.m. and then maybe at 1:30 they'll have their mental health visit, again within the walls of that FQHC. So it's typically, I usually see it whichever visit happened first, that's when they would be considered the new patient. And then when they do the billing for that mental health visit later in the afternoon, then they would be considered an established patient. So get that a lot. Modifiers. Modifiers is a big issue that we get questions on a lot. So specifically modifier 59. So FQHC multiple encounters on the same day. Modifier 59 indicates that separate conditions on, and I just noticed a typo, so I'm really sorry, on the same day that are treated on the same day but are unrelated. So you should only report modifier 59 for a subsequent injury or illness. This is, you wouldn't use modifier 59 when a patient sees more than one practitioner on the same day or has multiple encounters with the same practitioner on the same day, unless the patient subsequent to the first visit leaves the FQHC and then suffers an illness or injury that requires additional diagnosis or treatment on the same day. So a lot of words there, but it's really just saying if that patient came in for their AWB that morning, they left got into a car accident. They said they were fine, and later on in the afternoon, maybe they have nausea and vomiting, and they want to go back in to the FQHC and get some treatment. That would be an instance where modifier 59 would be appropriate to assign, because they're going back to the FQHC for a completely unrelated reason. So really want to watch coders just arbitrarily assigning modifier 59. We do see it quite often, but it truly is meant to be used only when that patient is coming in receiving treatment for something unrelated to the first visit. So just as an example of modifier 59 and what that would look like on a claim. Again, modifier 59 should only be used when reporting unrelated services that occurred at separate times during the day. So for claims subject to the FQHC PPS, modifier 59 is only valid with the payment code. So one of those G codes, G0467 in this case. So that patient left the facility. They had a regular established office visit, and maybe later on in the day they fell, they cut themselves, and they needed to go back for a laceration repair. So you would put that modifier 59 on the 12002 for the laceration repair to indicate that that patient came back. You want to assign modifier 59 to the subsequent service line to indicate the subsequent medically necessary visit. So you wouldn't put that modifier 59 on that initial medical visit. You always want to put it on what they're coming back for. So what the subsequent visit is. So what does that look like from an RHC's perspective? RHCs handle multiple encounters same day a little bit differently. From an RHC's perspective, modifier 25 is interchangeable with modifier 59. So just important to note there that RHCs do operate a little bit differently than an FQHC when coming across multiple encounters on the same day. Modifier 25 is defined as a significant, separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of a procedure or other service. So just in the broad sense of things, modifier 59 and 25 both indicate two encounters occurred on the same day. Modifier 25 or 59 is only on the subsequent service line item on a UB04, so on that claim form. Just as an instance, an example, the patient has a medical visit and a behavioral health visit on the same day, so they do have two visits. Or the patient has the IPPE and a separate medical or behavioral health visit on the same day. So they have 2 or 3 visits. You would want to use that modifier. Just as an aside, as a little tip, modifier 25 is not used to distinguish an evaluation management service from a procedure. So I want to make sure that you're not applying that 25 to like the 99213. You want to make sure it's being applied to whatever subsequently happened. And I do have an example here. So again, looking at it, and we'll talk about a couple things on this slide as well. So just as an RHC modifier example, from the subsequent visit, the 99213 is there with that CG modifier. And the subsequently medically necessary visit is there with the modifier 59 appended. So that patient came back for a laceration repair, and they applied that modifier 59 to the 12002. Important to note here that modifier CG and modifier 25 or 59 are not reported on the same service line together. So you never want to see that CG and a 25 or 59 on the same line. You want to make sure that that is delineated out and that you're putting the appropriate modifier on the subsequent visit. So this is the first time, or I should back up. I know I mentioned the CG modifier earlier that goes on RHC claims. So I did just want to point this out, that it is listed here, and just talk through a little bit about why that is and what that looks like. So beginning October 1st of 2016, RHCs were instructed to add modifier CG to the line with all the charges subject to coinsurance and deductible. If only preventative services are furnished during the visit, the RHC should report modifier CG with the preventative HCPCS code that represents the primary reason for the medically necessary face-to-face visit with the bundle charges. So again, a lot of words, and I'm a visual person. I like to see visuals. This is what that would look like. So you have your rep code 0521. The office visit for an established patient is the 99213, and the CG modifier is applied. So an established patient is seen and qualifying visit of 99213 for $100 is generated. So that coinsurance and or deductible is calculated using that $100. I did want to trying to move it. There we go. So just as kind of a billing example, if there are procedures performed in conjunction with a qualifying visit, the CG would be appended to the qualifying visit, and the procedure would be charged for just a penny. So it'll roll up into whatever that medical visit is. So here, like on this example, you can see if you were just billing for the procedure, you would put that CG modifier on the 11102, and that total charge would be $150. If that procedure is performed in conjunction with an office visit, it would be both the you'd bill the 99213, the 12031, excuse me, with the CG modifier on the 99213. However, when you go to charges, that would be $650 for the 99213, and you would only put a charge for the 12031 at a penny. That's typically how we see it done. That way you're being reimbursed, and the coinsurance and deductible are being calculated appropriately off of that medical visit. Oh, sorry. Let's see here. So I do just want to plug some resources that are available. I know we still have 30 minutes, but I have a couple more things to talk through. So the RHC qualifying visit list, I do have the link here. It is really, really helpful to go out there and look. There are obviously lots and lots and lots of codes. And even that is not all inclusive. There are several instances where you might need, and I'm gonna have to turn off my camera because I'm having some connectivity issues. So if Caleb, if something happens, just ping me and let me know. Let's see. Okay. Those qualifying visit lists are really beneficial to use if there are instances where like an IPPE is being performed, so that initial preventative physical exam and other screenings or what's the word I'm looking for? Like questionnaires take place. So if they're doing that tobacco abuse screening or the alcohol abuse screening, you want to make sure that you're using the appropriate code and applying that. And in that instance, you wouldn't want to use the 96127 code for tobacco cessation counseling. You'd want to make sure that you're using the tobacco abuse screening, so that G0442 code. The Medicare benefit policy, chapter 9 for RHCs and FQHCs is also really helpful. Just in kind of digging into more information for RHCs, it really breaks down the formulas for being paid on the air and what that looks like. And then from a reporting perspective, or a requirements perspective, what those locality guidelines are for establishing an RHC, also super helpful. Let's see. Again, from an FQHC's perspective, the qualifying visit, FQHCs do operate a little bit differently. So making sure that you have the established codes that link back to the G code. And I'm actually going to go back to the FQHC qualifying visit list. because I did want to make sure that I had enough time to talk through it. So looking at the G0466, obviously this is not an all-inclusive list, but if you're looking at it from like a G0467, it will be similar codes, but you'll still miss certain things. So like the behavioral change in smoking 3 to 10 minutes, the 99406, that would always fall under that G0466 FQHC payment code. On the flip side of it, if you have a behavioral health visit, so the G046, let me think about this, 69, those will obviously have a different set of codes. So if you're seeing an LCSW and you bill a 90791, you would want to make sure to use that G0469 code. And so it's really important to familiarize yourself with these FQHC qualifying visit lists and make sure that you have the ability to map it back to that G code. If you don't put that G code on the claim, majority of Medicare, that they want to see that. That's how they track, that's how they trend, and that's how they pay. So really important to make sure that those FQHC G codes get on your claim. And the same for an RHC. You really want to be able to capture what was done within that visit. Again, the claim tells the story. So just accurately getting those codes on the claim is half the battle. In terms of documentation, just making sure that the provider is documenting everything that was done. So that way the coders can apply. Coding can only apply what was done. So we do see a lot of instances, especially when those IPPEs and AWDs are performed. They make mention, hey, I gave this screening, or I gave this, I asked this specific question, but that wouldn't necessarily be able to drive a code assignment, just making that statement. So really want to make sure that educating providers on, hey, if you perform that annual alcohol screen, make sure that's documented. Make sure that screening gets into the chart. Make sure that you're documenting what that looked like. Did they pass? Did they fail? How many minutes? And the same with the depression screening. We see that a lot, making sure that that depression screen gets into the medical record, making sure that the provider makes mention that that was given, what their score was. So documentation is obviously a huge driver for coding. You can't code without the documentation. And we do see that a lot within FQHCs and RHCs, is just not having robust documentation guidelines or robust documentation practices to drive some of these code assignments. So just really important to educate those physicians regarding just accurate and specific documentation. Again, like we talked about, coding to the highest level of specificity. If that patient comes in and just say it's a behavioral health visit and they code F31.9, so I think that's major depressive disorder unspecified. Educate your providers and ask, hey, make sure you're documenting, is it recurrent? Is it chronic? Is it new? Is it severe? Is it mild? Was there psychotic features involved? Is there hallucinations involved? That way you can really make that code assignment even more robust and truly tell the story as to why that patient was there. Never want to discount the work that those providers are doing just because their documentation might not support all of the complexity, all of the thought process behind that provider making the code assignment. Similar to, if a patient comes in and they're diagnosed with, let's just say anemia or pneumonia, those are really what I'm going to call like high risk codes to assign. So you really want to make sure that those are, it's accurately documented, that they have all of that documentation there to support it. I think that those are ones that are typically targeted. If you have a specific bacteria identified, you want to make sure that that's documented for pneumonia. And with anemia, you want to make sure that those lab results are documented within the medical record so you can make an appropriate code assignment. Let's see. And then the same with, I'm going to skip ahead a little bit, the same with modifiers. Modifiers are truly important within the FQHCs and RHCs. because it's done differently than in just a regular medical facility. I've seen several instances, and this is just a little anecdotal story. That patient did come back several times throughout the day, and they were all for different reasons, but that provider just continued to tag along with that initial visit and never really made mention to the fact that that patient actually left and came back. And so, they missed out on that opportunity to really support that patient care and what that patient flow looked like. That was always an interesting story to me. So really just want to make sure that the documentation is there from a provider's perspective, so coding can accurately make that assignment. Let's see. Don't know if we have any questions. I don't think we do.
Not as of yet, but please, everyone, if you do have any questions, send them our way.
Yep, absolutely. I do want to go back to, and forgive me, I breezed through it because I don't know why I was anticipating questions. RHC multiple encounters, modifiers 25 and 59. We get it a lot from an RHC's perspective that it could be confusing that a modifier 25 and a 59 are interchangeable. Whereas in an FQHC setting, modifier 59 is the only one that is used or accepted. So in that instance, it would be, I typically see modifier 25 with, like we mentioned earlier, that procedure. So if they come back and a procedure is performed, but not necessarily a medical visit or an additional medical visit, I should say, you would append that modifier 25 to the procedure. On the flip side of it, modifier 59 is, I see it more often if that patient had their traditional medical visit in the morning, and then maybe they had some type of behavioral health issue come up, and they feel like they need to go back to that RHC facility and they need to seek treatment from their LCSW. Whatever that LCSW assigns, there would be a modifier 59 appended to that. So a little bit different than using that modifier 25, but they truly are interchangeable. We just typically see that when a procedure is performed, that 25 is assigned. And when it is an additional unrelated visit, that 59 is the one that's going to be assigned.
Hey, Caroline, it looks like we do have a question from Mr. Roland here.
Yep.
Hey, I just have a quick question. It's about your FQHC RHC location slide. Wonder if you could shift back to that just so I could kind of reference where you're going with it.
Absolutely.
So when you reference this, you said these are FQHC and RHC visit locations that can occur, correct?
Correct. Yes.
One of the questions I have is just about the unacceptable locations for FQHC and RHC visits. So with telehealth visits, if an RHC were provisioning care to a, let's say to a call or a PPS, according to this, it can't occur at an inpatient or outpatient setting at a call. If let's just kind of, make sure I'm getting the example right. So you have a distance site provider that's at an FQHC, you have an originating site at a call, and it's an inpatient or outpatient area of the hospital. That visit can't occur. Is that because of charging?
Yeah, so I think that would be based off of charging. I don't know that if the provider, the distance site is at the FQHC and the patient is not. That is interesting. Right. My gut reaction is to say, correct. You are correct. It is because of charging that wouldn't be accepted. But I don't want to say that is the end all be all answer, because I know that there have been a lot of regulation changes even in the past year with the waiver ending and evolving telehealth rules. But that is super interesting, and I definitely want to take that and get a better, more robust answer for you. But yeah, you're correct. My gut says no. Just in the sense that, CMS is pretty clear about where that patient has to be in order to be able to charge for it.
That's more of like a specific example because just the lesser volume of FQHCs. But with the RHC example, that one is a bit broader.
Yeah.
Because let's say you have a specialty, like a specialty that's in a RHC owned by a hospital.
Mhm.
And then from there, that specialty is working with an inpatient group at the hospital. So they're charging out of the RHC for an inpatient at their own facility.
Mhm.
So that, are you saying that that couldn't be charged?
No, I think from an RHC's perspective, I think that makes more sense.
So maybe just some clarity. I know that telehealth definitely adds a layer of complexity to it. But one of the questions that we build into with Delta facilities is if we could share resources,
Mhm.
you go across those resources, we
Right.
have to know how to navigate the waters. So
Yeah,
that could be
absolutely.
a really good item. If you have any, follow-up data that you find on it, we have that question pop up.
Yeah.
That one's one of them.
Yeah, 100%. And I do know that RHCs have a little bit more flexibility in terms of their telehealth, whereas FQHCs traditionally don't. I know that they are expanding. I know that that is definitely some of the CMS news topics that I've seen in terms of what FQHCs are going to be eligible to offer in terms of telehealth. I think from just an RHC's perspective, since they do have a more what I'm going to say like a broader purview, and in that example that you brought up of, it's a hospital-owned RHC department, and having that ability to reach across the aisle and, utilize all aspects of the facility, I think is super important. And so I will definitely follow up. I think that's a great question. And so I will get that.
Okay. Thanks so much, Carol.
Hopefully by the end of today for Caleb, so I can make sure that it gets dispersed appropriately.
Thank you.
Yeah, no, I appreciate it. That's great. Anything else? I'm sorry, Caleb, I can't pull my chat up because it does something to my screen.
Yeah, no worries. I will let you know if
Okay.
the questions right now. We do not. But again, everybody feel free. If you do have any questions, clarifying, any comments, just let us know.
Yeah, absolutely. Okay. Yeah, so FQHC and RHC, I was just study talking about locations. That sucks. FQHCs and RHC locations is definitely something that we see a lot of, or that we get a lot of questions, similar to what Mike's question was. As how does that work if it is telehealth, if it is a network of hospitals and they have different departments. So I think that is definitely something to research, and definitely something that we will get back to the group. And then as those guidelines are evolving, I know from a behavioral health perspective, they are working to approve IOP, so the intensive outpatient program services within the RHC setting. So that is also something to be on the lookout for from a rural health perspective. If you have a behavioral health patient that maybe doesn't need to be in an inpatient status, but it is something you can provide within your RHC setting. Those intensive outpatient programs are definitely there. They're up and coming from an RHC perspective. I just saw some guidance come through several weeks ago, or the beginning of this year, I should say, regarding just expanding those behavioral health services within an FQHC and an RHC setting. Right now they are fairly concise. There's not a whole lot there that can be offered in terms of outpatient services to really assist that patient. And so that brings a lot of additional challenges, like Mike mentioned, in terms of the location. Can they be offsite? Does it have to be within the RHC? Can they utilize office space somewhere for those group therapy type of services? And then what that looks like for the providers. Typically in an FQHC and an RHC, you only have those LCSWs and those clinical psychologists, where in IOP settings, we typically see we'll see anything from registered nurses to MA, I say MA, like masters of social work, masters of I've seen sociology before, and from a commercial insurer's perspective. And so just working through what that would look like go forward for those RHCs and FQHCs and what type of services can be rendered.
Yeah, that makes sense. And we have major struggles right now with just the provider staffing is really challenging too. So the broader approachable nature of trying to find LCSWs, trying to find all that behavioral health staffing, whenever it's, cloistered to, not being able to bridge between an RHC and a CAW or a FQHC and a CAW, it's tricky because we need to know what water to navigate, because like right now I'm already in that question. Like I asked you the question in reference to FQHC to CAW because that is a channel that I'm trying to work through. But there are, multiple avenues that are similar with the RHC status, where RHCs would like to have a mental health program and they'll be looking to bridge out to either their own hospital or an outside hospital. And to try to find that expertise, to try to find the expert that can help. So if that's coming from a call, or even a larger like PPS hospital or something like that, I mean, that's definitely a question of whether or not it's kosher to do that, to be able to bill. Yeah.
Even from a population health standpoint, I feel like that behavioral health need is definitely on the rise. I feel like that is something that is very it's talked about a lot right now. It's something that like a lot of those rural types of locations are missing. They're not able to extend across the aisle, like you said, to that critical access or to that PPS hospital to get those resources. And so if they can work through opening that up and, allowing some additional eligible providers, some additional eligible locations, just even right now, just as it relates to behavioral health, I think would be really beneficial, not just to the organization, but to like overall patient health as well. I mean, the overall driver for an FQHC and an RHC is to care for those patients that maybe wouldn't have care otherwise, or can't receive care that's not 100 miles away. And that extends to behavioral health as well. I mean, it's not just medical and your IPPs and AWBs. It extends to all types of services as well. So definitely hoping and definitely on the lookout for some additional IOP guidance. I feel like it's kind of the first foot in the door for those RHC locations. So if, IOP can make its way in, it could just open the door to lots of other services that could be eligible within that FQHC and RHC setting to better serve those patients.
We looked at that this week, with FQHC status, it's much easier for them to draw in mental health practitioners because they already have built-in mechanisms between, the primary care driver, the PCMH models that are attached to FQHCs.
Right.
I mean, those really drive home, especially the behavioral health pieces. So they are more attractive for mental behavioral health as like a stable profession. But if they can't bridge out and work beyond the FQHC, then it's really closeted to that work.
Yeah.
And that's what I was just in conversations this week about that, about, where can Delta facilities receive aid, and FQHC seems like a great avenue to look at, just because there's more clinicians there, and the pool in cause in PBS facilities is small. It's small. It's hard to get even at the RHCs too. So anyway, thanks so much. I'll be quiet now.
No, I love it. I love it. I definitely like discussion, so I appreciate all of that. I think it's great. And there really are some great resources out there for FQHCs and RHCs that detail some of these types of discussions, like what other people are experiencing in terms of Delta. Are they, and not even just Delta, but outside of Delta, and seeing what others are doing and how we can lobby to reach across the aisle and utilize some of those resources that we wouldn't otherwise have access to. I think is really important to serve the better need for patient care. So that's great, Mike. I really appreciate it. Anything else? I don't see any additional little like chat notifications that have come up. So otherwise, I don't have anything else, Caleb. I think
That sounds good. Yep, nothing, no other questions at this time.
Okay.
If anyone else has any last minute questions, please feel free to post them in the chat or come off mute. And in that time, as always, we're gonna start our post-polling questions. If you don't have any questions for Caroline, then after you fill out the post-polling, feel free to take off and have a wonderful break and or lunch break and a Thursday.